Greetings and a very warm welcome to all the dignitaries present here. I am Pronami from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as a digital partner for this event hosted by Indian Society of Anesthesiologists, Andhra Pradesh. Now, the focus of today's session is Postgraduate Orientation and Discussion Series. Now, I'd like to invite Dr. Praveen Kumar Muduri, sir, to proceed with the session. Over to you, sir. Thank you very much.
Thank you, Pranam. Good evening. On behalf of ISA Vishakhapatnam City Branch, I deem it an honor to welcome you all to the 6th session of Postgraduate Orientation and Discussion Series. Today, we are truly honored and privileged to have with us Dr. Jigeshu Visishta Divatia, sir, as the guest speaker. As we all know, sir's academic excellence is truly unparalleled. Sir has been the past national president of ISA, past editor-in-chief, Indian Journal of Anesthesiology, and he has been serving the Indian Society of Anesthesiologists for more than 3 decades now. Presently, Sir is the head of the Department of Critical Care in the famous Divatia Hospital and Research Center, Mumbai. Object to Anesthesia Review, the favorite textbook, not only and it is not an countless postgraduate students. Today, Sir will be talking on a very important and clinically significant topic, ARDS, and I am sure his insights will be extremely valuable to all of us. And the expert panel of moderators for today evening are Dr. K. Venkateshwara Sir, former professor and head of the Department of Anesthesiology, Andhra Medical College, Maharaja Institute of Medical Sciences, Vijayanagaram, and also Department of Anesthesiology, Ashram Medical College. We also have Dr. Alu Padmaja Madam, Additional Director Medical Education and Superintendent GGH Vijayanagaram, Dr. Padma Amar Vishal Madam, Professor and Head of the Department of Anesthesiology, NRI Institute of Medical Sciences, Vishakhapatnam. The moderators will be guiding the session with their experience. We are also honored to have the stalwarts and torchbearers of ISA Anesthesiology along with us today. The past national presidents of ISA, Dr. Kameshwara Sir, Dr. Chakrarao Sir, Dr. Kuchela Babu Garu with us, and also the representatives of City Branch. May I request Dr. Kameshwara Garu, Kuchela Babu Sir, to say a few words before start of the session. Kameshwara Sir.
Good evening, everyone. Good evening, everyone. I am happy today that Dr. Divatia has taken time to spend with us with his academic excellence. And the topic selected is really very useful for all the postgraduates. And I appreciate the Vizag City Branch for conducting regularly this postgraduate orientation and discussion series, and with the very useful topics. And I appreciate and congratulate the City Branch of Visakhapatnam. And I ask them to continue the same spirit in future with all the good speakers. Thank you.
Thank you, sir. Kuchela Babu Sir, to say a few words.
Yeah, it is good evening, all of you, especially accepting your invitation by Dr. Divatia sir for delivering his excellent talk on ARDS. We know it will be benefited especially by our postgraduates in Visakhapatnam and also Andhra Pradesh. And we are doing this part sessions. This is a 6th session. I think we'll continue for future also. It's a very good initiative done by Praveen. I hope it will continue in the future also. Thank you very much. I welcome the Divatia sir for his presentation and all the delegates.
Thank you, sir.
For today. Thank you very much.
Thank you, sir. Chakrarao sir has also joined. Sir is in journey, sir. If it is possible, a few words. Sir, mute on, sir. I think sir is mute. Okay. Now I request President of the City Branch. Sir, unmute cheyal, sir. Chakrara, sir. So I request President of City Branch to give a brief remarks.
Respected senior colleagues, esteemed faculty, dear postgraduates, and members of the Indian Society of Anesthesiologists, good evening. It gives me immense pleasure to welcome you all to the sixth session of PODS. What began as an academic initiative has now evolved into a meaningful platform that reflects our collective commitment to continuous learning, clinical excellence, and academic engagement. Reaching this milestone is not just about numbers, it represents the consistency, curiosity, and a shared passion for improving patient care. Each session has added value, and today we take the momentum forward with the topic of sits at the very heart of critical care practice. Acute respiratory distress syndrome is not just a diagnosis. It is a true test of clinical judgment, vigilance, and multidisciplinary coordination. Managing ARDS challenges us to balance science with experience and protocols with personalization and urgency with precision. We are truly honored to have with us today an exceptional clinician, teacher, and thought leader, Dr. Jigeshu Vasista Divatia. Welcome, sir. His contribution to anesthesiology and critical care have shaped practice standards across the country. Sir, your presence today elevates this session into masterclass, and we are grateful for your time and guidance. I also extended my sincere appreciation to our distinguished moderators, Dr. Venkateswar sir, and Dr. Padmaja ma'am, and Dr. Padma Amar Vishal ma'am. Welcome ma'am, welcome sir, whose vast experience and insights will undoubtedly enrich today's discussion and help translate knowledge into practical understanding. As president, I take pride in witnessing the growth of this initiative and the enthusiasm it has generated. Let us continue to build on this foundation and strive for excellence in both learning and patient care. With that, I once again welcome you all to this session and look forward to an enlightening and interactive discussion. Thank you, sir.
Before we start the session, a small reminder to all the participants that if there are any questions, kindly post them in the chat box, which will be answered at the end of the session. Thank you. Now, I request the moderators to take the session forward.
Good evening, everyone. It's a pleasure and honor to introduce today's guest speaker, Dr. J.B. Divatia, who is a senior and famous anesthesiologist with immense clinical experience. At present, he is working as the head of the Department of Critical Care in Divatia Hospital and Research Center in Mumbai. And previously, he worked as HOD of Anesthesia and Tata Memorial Hospital, Mumbai. He was also the past director of HP Cancer Hospital, Punjab. And he was the past president of ISA National and past editor-in-chief in Indian Journal of Anesthesiology. He was also the past president of Indian Society of Critical Care Medicine, All India Difficult Airway Association, and Society of Onco Anesthesia and Patient Care. And he has more than 30 years of service. He has done more than 30 years of service to ISA, and he has more than 180 publications to his credit. And his book, ARDS textbook, is very famous among the postgraduates. And his guidelines on pre-op investigations, difficult airway, calls BCLS and CCLS are widely followed. And we are really honored to chair the session, sir, being presented by you. Please commence the topic, sir. And Dr. Padma Vishal and Dr. Padmaja, if you want to talk something, you please talk.
Sir, good evening all. Today is I feel very nostalgic, sir, because the ISA City Branch Visakhapatnam has been growing in academic activities. Thanks to Dr. Praveen, the Secretary of ISA City Branch, Anuradha, and the President, and senior faculty, Dr. Venkateshwara sir, Kuchal Babu sir, for guiding them in a proper manner. It has started in 2022, October 16th, YouTube channel. And then now the anesthesia diaries and podcasts and a lot of webinars. And today we have got a distinguished speaker, Divatia sir, with us to enlighten the students and the faculty in a very interesting topic. Thank you, sir.
Good evening, ma'am. Good evening, sir. It's our privilege to have you here, Dr. Divatia, sir. Being listened to you in many platforms, we are feeling so much privileged to moderate your session. Thank you, sir, for accepting this. And thank you, ISA City Branch, for giving this opportunity. Thank you.
Sir, you can please commence the topic, sir.
Yes. Good evening, sir, and thank you very much for inviting me to this very innovative and nice initiative of the pods. I'm honored to speak here in front of eminent past presidents of ISA, Dr. Chakra Rao sir, Dr. Kameshwar Rao sir, Dr. Kuchela Babu sir, and thank you very much for the very kind words of introduction. So let me get to the topic, and I hope you can see my slides and you can hear me well.
Yes, sir.
So I will be speaking on ARDS, or the acute respiratory distress syndrome. Now, so just see this patient, he's got old case of rectal cancer. He now presents with malaria and he seems to be stable, but when you do his X-ray, this is what his X-ray looks like. He's tachypnic, of course. And he's got severe hypoxia. On a non-rebreather mask, his PO2 is only 60. He's got this X-ray. The CVP is 12 and the heart seems to be normal. So the question is, is this ARDS, right? And it looks like ARDS, and we all think it's ARDS. But if you actually look at the definition of ARDS, and this is the standard definition of ARDS, which has been followed for many, many years, and it's called the Berlin definition, which was defined in 2012. So firstly, it has to be acute, right? So the timing has to be within 1 week of a known clinical insult or known or new worsening symptoms. Now, this is important because it means that ARDS is not a specific disease. It is something, a syndrome. So it's that happens in the setting of some other illness, right? And so there is usually an underlying illness, which may be within the lung, which we call as pulmonary ARDS, or it may be extra pulmonary, so outside the lung. So the primary problem may be is something else, and then you get insult to the lung, to an injury to the lungs, and that has to be acute. So within 1 week of that known clinical insult. On imaging, you should see on the X-ray, you should see bilateral opacities, and this obviously this should not be effusions or collapse or nodules. It is very important that these opacities or this infiltrates are not explained fully by cardiac failure. Of course, you can have someone with heart disease who also gets ARDS, but it should not be, the infiltrate should not be fully explained by heart failure or fluid overload. And you need some objective assessment to say that, well, the heart is not so bad, or that there is also a respiratory component, not just a pure cardiac component. And in the past, people used to insist, the older definition used to insist on a pulmonary artery catheter. But now even an echo or even a CVP or good clinical judgment may be accepted in certain circumstances. But echocardiography is widely available, and you need to do an echo to rule out heart failure on hydrostatic pulmonary edema. Right? Now, once you have these things, then you have whether it's mild, moderate, or severe ARDS. And mild, to define that, we use what we call as a PF ratio, or the ratio of the PaO2, arterial PO2 to the FiO2. And if it's less than 300, so between 200 and 300, we call it mild. Between 100 and 200, we call it moderate. And severe is the PF ratio is less than 100 millimeters of mercury. Now here, there's a very important caveat. It says that you should have a PEEP or a CPAP of 5 centimeters of water. In other words, the definition of ARDS already presumes that this patient is receiving either invasive or non-invasive mechanical ventilation where PEEP or CPAP is being given. Okay, so this is one of the sort of lacunae of the Berlin definition. It presumes that the patient is already receiving some kind of mechanical ventilation. So strictly speaking, by this definition, our patient cannot have ARDS. So if you want to publish it, you would say this is not ARDS because he still is not getting CPAP or PEEP. So, and this has been, and especially after COVID, people recognize that, you can have severe respiratory failure. People were on high flow nasal oxygen, people were on non-rebreather masks. And of course, they had something which is almost like ARDS, but, it didn't fit that definition. So now we've got what we call as a new global definition of ARDS. And this takes into account the fact that patients may be on various types of respiratory support apart from invasive or non-invasive ventilation, very often high flow nasal oxygen, sometimes just a high flow or non-rebreather oxygen mask. And so again, so it has a risk factor in origin of edema, which you know, and timing is within 1 week of this thing. And now chest imaging previously focused largely on chest X-ray and CT scan and so on. But now the new global definition also takes into account the fact that ultrasound is being increasingly done in ICUs. And so even if you have B lines, on the lung ultrasound, it is accepted as part of the definition of ARDS. So you can have either infiltrates in the chest X-ray or CT scan, or even B lines on the ultrasound. Okay. And then you have different types of ARDS. So you can have, like I mentioned earlier, you needed to have a tube or a non-invasive mask. So here you have a non-intubated ARDS. So here you've got a PF ratio less than 300, and then the same category. And very importantly, in many parts of the world, they may not have access to frequent blood gases, and you may not be able to do a blood gas. So instead of a PF ratio, which is the arterial PO2, they now have the SpO2 to FiO2 ratio, the SF ratio as they call it. Right. So the SpO2 to FiO2 ratio, if it is less than 315, right, either on high flow nasal oxygen or on NIV, then you say this is non-intubated ARDS. Okay, so at least this part allows high flow nasal oxygen with a flow of at least 30 liters per minute, or you can have non-invasive ventilation or CPAP. Then you have intubated ARDS, and again it follows the same 3 categories of mild, moderate, and severe. And again, now you have, apart from PF ratio, you've got SF ratio 315. So 235 to 315 for mild, SF ratio of 235 to 148 for moderate, and less than 148 for severe ARDS. And of course, the PF ratios ranges remain the same. They have also modified the definition for places which are resource limited and which may not even have blood gases, we may not even have ventilators, but they can just, or high flow nasal oxygen for that matter, and are just giving high flow oxygen via an under-breather mask. In which case, you say you don't need any sort of gadgets or nothing. But if your SF ratio is less than 315, then then you can still diagnose ARDS. So now this is a global definition which caters to different types of respiratory support. It includes all types of respiratory support, and it also includes all sorts of resource settings, the high resource settings as well as the limited resource settings. Okay. Okay. Now we know that ARDS is a result or associated with a underlying clinical condition, and like I said, it could be a direct lung condition, and these are the common causes. Bacterial pneumonia or a viral pneumonia is very common. COVID-19 is I hope we don't have to live to see it again. Aspiration pneumonia, lung contusion, and so on. And indirect injury to the lungs could be sepsis in any other part of the body. You could have trauma, you could have shock, you could have pancreatitis, CP bypass, transfusion-associated lung injury, or many other conditions. So acute ARDS occurs in the setting of diverse sort of situations, and it must occur within 1 week of these sort of settings. We've got very important causes of ARDS in India. And of course, we all know that you get severe malaria, you get leptospirosis, you get hemorrhagic fevers. Scrub typhus is very prevalent in some parts of the country. H1N1 flu is also very common. The important thing is it is extremely important to have a treatable cause, and many of these tropical infections are treatable, and we must be able to treat the underlying cause well to treat ARDS, because if you're not able to correct the underlying condition, then your prognosis of ARDS becomes that much worse. Okay, now once you have a patient who's hypoxic like this, what should you do? Should you give intubate or should you give high flow oxygen or non-invasive ventilation? Now, it is very tempting to give to avoid intubation, and especially in COVID, we saw that many non-anesthesiologists who are not comfortable with tubes, not comfortable with intubation, not comfortable with ventilators, they did not want to intubate patients, and they gave either high flow nasal oxygen or they gave non-invasive ventilation. Sometimes we are tempted to do so in immunocompromised patients because you think that intubation might increase the risk of superarid infections and so on. So we'd like to give some non-invasive ventilation to these patients. It is all right. So we'll talk about that. But one principle we need to keep in mind is that patients who are spontaneously breathing and who are extremely breathless, they have large intrapleural pressure swings. They breathe, they have that gasping kind of breathing, they take deep breaths. So the intrapleural pressure is very negative. Now, if you give positive pressure by a non-invasive ventilators, let's say you give a pressure support of 10 or 12, and the patient is taking deep, has a strong respiratory drive, and he's taking deep negative pressure inspiratory breaths, and let's say the inspiratory pleural pressure, which is normally about -5, -2 to -5 when we breathe normally, it's now say -20 or -25, and then you give a positive pressure of 10 or 12 centimeters of water, then the transpulmonary pressure, which is the airway, which is a difference between the airway pressure, which is 12, and the pleural pressure. Now the pleural pressure is -25. So it's 12 minus -25, right? So the transpulmonary pressure is 37, which is a very, very strong positive pulmonary pressure, which can cause lung injury, right? So we'll talk about all these mechanisms, but it is important to understand that patients who have lung injury, who have injured lungs, who are spontaneously breathing with a strong respiratory drive, with strong negative intrapleural pressures, they can develop this pattern of lung injury, which we call as patient self-inflicted lung injury, or PSILI, PSILI, which is a very unfortunate thing because the patient is not doing anything to damage the lung, but the lung is getting damaged because we are adding pressure support to his strong negative intrapleural pressure. So if you just need to keep in mind that even with spontaneous breathing on a ventilator with patient with severe pneumonia or something, you can actually exacerbate lung injury. So just keep that in mind, right? So in acute hypoxic respiratory failure, while we think that non-invasive ventilation is good, we must understand that there is a risk of patient self-inflicted lung injury. Okay, and therefore you need to monitor these patients very carefully. And if they don't improve rapidly in a few hours, then I think we should cut your losses and go to intubating these patients. The other danger of giving non-invasive ventilation to these patients is you delay intubation. You just keep pushing it back, keep increasing pressure support. A patient is breathless, you keep giving sedation, and you try and cut down the respiratory drive by that sort of by pharmacological means. And then you might actually end up doing harm and intubating your patients too late. And that is another important cause of mortality with non-invasive ventilation. So you can try non-invasive ventilation, acute hypoxic respiratory failure. But especially if the respiratory failure is severe, if you've got moderate to severe ARDS, then maybe you should not wait too long and go to intubation sooner rather than later. Okay. If you've got the patient on high flow nasal oxygen, then there is an objective parameter to decide whether you should intubate or not. It's not the only parameter, but it helps you along with other parameters to decide whether to intubate the patient or not. And that is called the ROX index. And the ROX index is a rate to oxygenation index. So that is the pulse oximeter, SpO2 saturation divided by FiO2 divided by the respiratory rate, right? So if you've got a saturation of 85% and you are on 100% oxygen, so this is so 85 upon 0.85, that's 100. 10 divided by your respiratory rate, which say is 40, then your ROX index is actually very low. So the lower your ROX index, the higher is the indication for tracheal intubation. And if your ROX, and that there are different time frames, there are different cutoffs at different times, but at any point in time, if your ROX index is more than 4.88, then you're probably safe and you can continue to give high flow nasal oxygen. But if it's less than 4.88, you need to consider intubation. And you need to, the lower the ROX index, the closer you are to intubating this patient. Okay. So these are some recent guidelines which were published a few years ago, the European Society guidelines in ARDS. So that they recommend that patients with acute hypoxic respiratory failure, high flow nasal oxygen is better than conventional oxygen therapy. Okay, it's better than conventional oxygen therapy. However, they are not sure whether it is better than non-invasive ventilation as far as mortality is concerned. Okay, but given the risk of self-inflicted lung injury, high flow nasal oxygen may have some advantage compared to even non-invasive ventilation. Now, once you've intubated the patient, okay, then you have to have a strategy on how you're going to ventilate these patients. Now, our understanding of ventilation ARDS has changed dramatically once we have understood the concept of what we call as ventilator-induced lung injury. Now, when ARDS was first sort of discovered in the early 70s, right? It was first described in the early 70s. Patients had stiff lungs because the lung compliance was very low. And then in order to ventilate these stiff lungs, at that time, they had to generate large tidal volumes to get air into the lungs. And that resulted in high peak pressures, right? So that was because the lungs were stiff and the FRC was low, they were opened up with the PEEP, and PEEP levels of 10 to 15 were not uncommon. They required high FiO2s, and you had to and the aim at that time was to keep the blood gases near normal. So you wanted the PO2 to more than 80, so close to normal, and the CO2 to be less than 50, again close to normal. So in order to achieve the goals of relatively normal CO2 and PO2 levels, you will end up giving high tidal volumes, high peak pressures, high PEEP, and high FiO2. And when autopsies were done in patients who died of ARDS, they found the lungs looking completely battered like this. Okay. And then the question was, is the lung looking so bad because the disease was bad? Is this a diseased lung, or the lung has been so badly affected because of the underlying disease? Or has the ventilator got to do something with it? Has mechanical ventilation causing some of this injury? And a lot of people argued, well, the lungs were bad, and no wonder you're getting a dirty looking lung when you do a post-mortem and you see the lung outside the body. And ventilator-induced lung injury was a concept, but no one was very sure whether something like ventilator-induced lung injury existed. And a lot of people were very familiar with barotrauma because obviously when you gave such high tidal volumes and pressures, pneumothoraces were very, very common. And until this sort of animal experiments which were done, I think these were done in rats. Okay. So what these investigators did was, these are rat lungs. Okay. And some of them, they gave, so these patients were ventilated with high tidal volumes, which resulted in high airway pressures. Okay. So you got high volumes and high pressures. Okay. And some rats were ventilated with low tidal volumes, but their chest was strapped. So the chest wall compliance was reduced. And because the chest wall compliance was reduced, even with the low tidal volume, they achieved the same high pressure. So both rat lungs were exposed to high pressure. This lung was exposed to high tidal volume. This was not exposed to high tidal volume. And what they found, that the injury was highest in lungs which were exposed to high tidal volume. So while barotrauma pneumothorax was understood, now the concept came of volutrauma. It was just the high tidal volume. With the same pressures, the higher tidal volume was damaging the lungs more. Okay, so this was the concept of volutrauma. So now there was lung injury, and volutrauma was identified as one of the major factors causing lung injury in ARDS. But the real big breakthrough in ARDS ventilation came when people started doing CT scans of the chest. See, up to now, the lung in ARDS on the chest X-ray looked very homogeneous sort of injury, bilateral homogeneous lung injury, as you saw in the first slide. But when you did a CT scan of the patient, when the patient was lying down, you found that there were actually three sort of reasonably distinct zones. the most dependent zones, right, at the bottom, right, in the line, the patient who's lying supine, the most dependent zones were the most densely affected. You can see that the lung is completely collapsed, consolidated. There's very little air over there. Then there was a zone which was less affected. You can see infiltrates, but you can also see a little bit of aerated lung. And the most non-dependent area, the one most anterior, the most non-dependent area was actually completely normal, right? So you could see that this lung is virtually like a normal lung. So now you can see that this part of the lung is not being ventilated at all. There's no air going in here. Some air goes in here, probably when you give positive pressure, this lung opens up, but it doesn't open up. It collapses during expiration. And this lung is open throughout inspiration and expiration, right? So this lung, the volume of this lung is only half to 1/3 of the entire volume of the lung. And that's why they called it the baby lung, right? Now you can imagine that if this baby lung, which is 1/3 or half the volume, gets a high tidal volume, when you and I breathe, we breathe about 6 to 7 ml per kilo, right? That much is our tidal volume. You're giving them almost double, 10, 12, 14, 15 ml per kilo, because you're trying to ventilate a stiff lung and get normal blood gases. So if you're going double the tidal volume to half the volume of the lung, you're going to over-distend these alveoli. And we know now that volutrauma is very important, and over-distension of the alveoli is a major, major problem. So first, one very important mechanism of ventilator-induced lung injury, it was what we call as over-distension or stretch trauma or volutrauma. Okay. Now, these were alveoli which are, now you're ventilating the patient, right? Positive pressure ventilation. So this is expiration, this is inspiration, and this is expiration again inspiration, so on. Now, these alveoli are at the most non-dependent area, right? So right at the top, and they are, like I said, they are normal lung almost. So they remain open throughout in expiration, and they open up further during inspiration, and they come back to a resting state where they are still partially aerated. Okay, so these alveoli sort of open throughout the respiratory cycle. At the bottom, the most dependent area of the lung, I said these are completely collapsed, and they do not open even up with this positive pressure. They're so densely collapsed and consolidated. In the middle zone, however, these alveoli collapse during expiration, open up during inspiration, and again collapse during expiration. So in other words, with every breath, these alveoli are opening and closing, opening and closing. And this repetitive opening and closing of alveoli also produces lung injury, and that is called as atelectatic trauma, okay, or repetitive opening and closing injury, or atelectatic trauma. So, okay. Now these lungs, if these alveoli are over-distended, you give a very large tidal volume. These are over-distended and you get volutrauma. So in the most non-dependent area, the alveoli are subject to volutrauma. In the mid zone, they are subject to what we call as atelectatic trauma, right? And at the junctions of alveoli which are normal and opening and closing, and alveoli which are collapsing, you get shear force stresses being generated, and they also cause lung injury, right? So now you've got volutrauma, you've got atelectatic trauma, and you've got shear stress injury. Also, when you give PEEP, right? So when you give PEEP, this is what happens to alveoli which are in the mid zone, right? So they're collapsed during expiration, right? And they open up. When you give PEEP, these alveoli now remain open throughout the respiratory cycle, because with PEEP, they open up during expiration as well, and they remain open. Of course, they open up during inspiration and they remain open throughout the respiratory cycle. So PEEP is very, very important, not just because it improves PO2 or it reduces the amount of fluid, but because it protects the lung by reducing atelectatic trauma, right? But just keep one thing in mind, a caution about PEEP. This is what's happening in the mid zone, but in the upper part, non-dependent area, the alveoli which are completely open, if you give too much PEEP, then you can get over-distension lung injury. So PEEP is good, but it's a balance. The right amount of PEEP is a balance between that which prevents atelectatic trauma, but also does not cause over-distension or volutrauma. So even today, as we speak in 2026, we don't know the best way to apply PEEP, but conceptually, the right amount of PEEP will protect the lung from atelectatic trauma and will not cause volutrauma. Now, all these things, this over-distension, repetitive opening and closing, shear stresses, they generate inflammation within the lung. And that causes what we call as biotrauma. So inflammatory mediators are released because of this inflammation. And these mediators, not only do they damage the lung further, but then these mediators get absorbed into the circulation and then they go to distant organs and cause endothelial damage and multi-organ failure. So what starts as an ARDS in the lung can then result in multi-organ failure throughout the body. So how do we get around this problem? So we now know that giving high tidal volumes and causes in a patient with ARDS causes endothelial damage, inflammation, and in the lung and in distant organs. So obviously, you know that you're dealing with only 1/3 with the baby lung, so you have to reduce your tidal volume. So one simple strategy would be to reduce the tidal volume, give lower pressures. And once you do that, you know that you will prevent all these sort of problems which are going to happen. But when you give low tidal volumes to these patients, you're going to hypoventilate the patient, right? And then you're going to get a rise in PCO2. So you'll protect the lung, but you will get a PCO2, which is high because you're giving lower tidal volumes. And the philosophy is that it is better to accept a high PCO2 rather than give injurious lung ventilation and cause all these problems. And this philosophy is called permissive hypercapnia, right? So you accept some respiratory acidosis, accept a little high CO2 in the hope that you will prevent lung injury, which is actually damaging the lung and killing the patient. Okay, so this was a sort of concept of protective lung ventilation in ARDS, and this was tested in a very famous trial, which all of you must read or must have read or know by now. It's called the ARDS network trial, and they compared a low tidal volume of 4 to 6 ml per kilo and a plateau pressure less than 30 centimeters of water. Now, a plateau pressure of less than 30 centimeters suggests that the lung is not over-distended. A plateau pressure more than 30 centimeters of water suggests the lung is over-distended, right? So you give a low tidal volume, make sure the lung is not over-distended by checking the plateau pressure. So set your plateau pressure goal as less than 30 centimeters of water. And they compared that with a conventional sort of traditional tidal volume at that point in time, 12 mils per kilo. And they found a dramatic reduction in mortality. Okay, so this trial sort of validated all the experimental models and all the theoretical thought that was going in and said that this is how we now need to ventilate our patients with ARDS. Okay, now there has been more understanding of ventilator-induced lung injury. So, for example, we already know that there was barotrauma, we know, volutrauma we've seen, we talk of stretch trauma, atellect trauma, and biotrauma, right? Now, it is also important to recognize that the ventilator is blowing air into the lung, right? So therefore, it's imparting some energy as air gets blown into the lung. And this is called ergotrauma, energy trauma or ergotrauma. And that is defined in terms of strain, which is a change in transpulmonary pressure. Remember, I talked about transpulmonary pressure, and stress, which is the volume strain. So which is the tidal volume, or more importantly, the ratio of tidal volume to FRC. So in a baby lung, you've got a small FRC, you give them a high tidal volume, you have that much more stress, right? So that damages the lung. Okay, I think I'll just skip this. Very recently, in the last few years, we've also got this concept of mechanical power. Like remember that the lung is imparting a certain energy and is giving force. So there's a sort of power which is being imparted to the lung. Okay, and apart from the standard of what we know as respiratory rate and pressures and the tidal volume and PEEP, we are now focused on the respiratory rate, because the higher the respiratory rate, the greater power is being imparted to the lung. And maybe we also need to control the respiratory rate if you want to reduce lung injury. Okay. So the standard ventilatory strategy in ARDS is, you prevent alveolar overdistension. And for that, you give a tidal volume of 4 to 6 mils per kilo and make sure that the plateau pressure is less than 30 centimeters of water. And in this mid zone, you keep the lung units open by using appropriate amounts of PEEP. Okay. So this was the sort of ARDS net protocol. And essentially in that study, they used volume control ventilation, but you can use pressure control if you like. But irrespective of the mode of ventilation, you need to make sure the tidal volume is 6 ml per kilo of ideal body weight or lower. Remember, it's ideal body weight. And the ideal body weight depends only on the height and the gender of the patient, right? Now, I may be weighing whatever I am today. If I double my weight, my lungs don't double in size. My lung size remains the same. That's why it's 6 ml per kilo of ideal body weight, right? The plateau pressure should be less than 30 because that suggests that the lungs are not over-distended. And then you increase your PEEP and FiO2 or decrease your PEEP and FiO2 based on a table, which I'll show you, to prevent hypoxia. And although you accept hypercarbia, it doesn't mean you allow the CO2 rise indiscriminately. if the CO2 rises, then you increase the respiratory rate and try and bring the CO2 to normal to about 35. And if the pH remains below 7.2, then you give a slow infusion of bicarbonate to correct the pH. And remember, very importantly, your goals of treatment. You are not aiming for normal or high normal PO2s. You're aiming actually for low normal PO2s, a PO2 of 55 to 80 millimeters of mercury, or saturations of 88 to 94%, right? So you're not aiming for 99 and 100% saturation. You're aiming for a safe saturation. Remember, the higher the target you set, the more aggressive ventilation you will do. And what we want to do is avoid aggressive ventilation, do gentle ventilation, which will not damage the lung, but at the same time will keep the patient safe, right? So these are sort of safe limits. In COVID, we've tolerated 80%, 75% at times, okay, as long as the patient has otherwise been okay. But I think that's a bit too much. We did it because we were forced to. But otherwise, 88 is a reasonable low target, which is acceptable. Of course, there are some patients in whom we will not accept high CO2, like pregnancy, intracranial hypertension. Okay. And of course, remember your plateau pressure goal. Now, plateau pressures, you can either set it on your ventilator or you press the inspiratory hold button on the ventilator, and that will, the pressure that you get is the plateau pressure. It should be less than 30. Arterial pH goal should be less than, more than 7.3. And of course, the whole idea is to prevent ventilator-induced lung injury. Now, how do you adjust the PEEP? So you adjust the PEEP and the FiO2 to get your oxygenation goal, right? So, and what you do is you adjust your FiO2 and PEEP together. So if, for example, if you're on 40% and 8 of PEEP and you find the PO2 is below your goal, then you increase to the next step. So increase both the PEEP and the FiO2. So as per this table. So you go to 0.5 and 8. You still not achieved your goal, you go to 0.5 and 10. You still not achieved your goal, you go to 0.6 and 10. Okay. And same way when you're coming down, you come down and follow this. Now, this table was made by a group of experts sitting across the table, and they thought this is the best way to do it. It seems to have worked. They got very good results. So we all follow this table. Okay. And another important this thing of using a table like this is everyone does the same thing. No one does adjust PEEP and FiO2 arbitrarily on their own. Everyone does it more or less as per this table. Some people argue that, no, but this is just some group of experts sitting having tea or maybe whiskey and deciding how much PEEP and how much FiO2 to have. We should actually go by the mechanics of the lung, and maybe you should use the PEEP which is associated with the best static compliance, right? And this is the formula for the static compliance. That is tidal volume divided the plateau pressure minus the PEEP, right? The set PEEP. So this, of course, to see the plateau pressure, you need to do the inspiratory hold, and you need to see the static compliance. So you keep increasing the PEEP, and the PEEP at which you get the best compliance is the PEEP that you need to set. So now this is what we are doing. And some people argue, you're keeping the lung units open over here with PEEP. Of course, you're giving protective ventilation. What about this area, which is completely collapsed? Maybe we can open it up by giving high PEEP, a very transient, right? A transient high PEEP or a transient high tidal volume to open up this bottom area of the lung, and that they call as a recruitment maneuver. So open the collapse with a recruitment maneuver, and obviously this lung will have to be held open by a higher amount of PEEP, right? So that's what's called a recruitment maneuver, and this whole thing sort of kept the whole lung open. Now, there was this very famous trial which was done, it's called the ART study, ART study, and they actually looked at recruitment maneuvers and high PEEP versus the standard sort of ventilation which you are doing. Okay. And what they found to their shock, what they thought they would do well, they gave a recruitment maneuvers with increasing levels of pressure support for some time over a minute. But they found that the strategy of recruitment maneuvers and high PEEP resulted in a higher mortality. So we do not recommend this strategy anymore. So no recruitment maneuvers on a routine basis, and not very high PEEP to all these sort of patients. Okay. So our conventional low PEEP FiO2 table and protective lung ventilation with low tidal volume seems to work best. And all these things you may do in desperate situations to improve the PO2, but certainly not on a routine basis. Okay. So the European guidelines say that, you stick to the standard FiO2 PEEP table because there's no evidence that a higher PEEP sort of seems to work. They are not able to say whether PEEP based on respiratory mechanics like static compliance seems to work better than the standard PEEP FiO2 table. Okay, they recommend against the use of high pressure recruitment maneuvers, and they suggest against the use of any kind of recruitment maneuver for that matter. Okay. Now, another new concept has come is called the driving pressure. And this concept of driving pressure is now also used in the operating room when uh, when you've got some of these newer of these good workstations, they also do the driving pressure. Now, what do you mean by driving pressure? So driving pressure, or it's called a delta P, is the ratio of the tidal volume of the respiratory system compliance normalized to tidal volume. Okay. Now, in a normal patient, it's the entire lung, right? Which is so you've got the compliance of the entire lung, and the whole lung is getting the tidal volume. Okay. In a ARDS lung, remember the tidal volume is going only to a small part of the lung. So the compliance only of that part of the lung. So you have to normalize the tidal volume, the respiratory system compliance, the tidal volume to the functional lung size, right? So, and when you put this formula in, I won't go into the detail. When you just put in the formula for compliance, respiratory system compliance, then the driving pressure is actually plateau pressure minus speed. So this is now very commonly used when patients are ventilated, who are sedated or paralyzed and ventilated. The driving pressure is plateau pressure minus speed. And these ventilators, they did a sort of study. And what they found, like we talked that high tidal volumes are bad, too high a PEEP may be bad, okay, and sometimes and that sort of thing. But what these pressure people found is that no, it is not only the PEEP or only the tidal volume. It is a driving pressure which actually drives the mortality. So if you set the PEEP high, if you go on a higher PEEP, see, when you give a higher PEEP, you think you will recruit more lung, right? You'll open up more lung. Now, if you open up more lung, your compliance should improve, right? So in which case your driving pressure should drop because your plateau pressure will drop. So any maneuver which decreases your driving pressure is good. Any maneuver which increases your driving pressure is bad. Okay. And if your driving pressure remains the same in spite of your maneuvers, it means that whatever you've done is not acting, is not making a difference. Okay. So whenever you set PEEP, before you increase the PEEP, you should check the driving pressure. And if increasing the PEEP decreases the driving pressure, then it's good. If it increases the driving pressure, it's not a good PEEP to set. Okay. So that's one more thing. And they also found that if your driving pressure is 15 or more, you have a higher chance of dying. That doesn't mean you should try and reduce in some stiff lungs, it is impossible to get a driving pressure of 15. I mean, it'll be 17, 18, 19. But the bottom line is that whatever ventilator setting you do should not increase your driving pressure from what it was before you made the change. I hope that's clear. One more very important thing we've found is that the prone position makes a big difference to outcome. Okay. Now it works in various ways. Now, for example, this is the bed. Okay. So this is the patient lying in the prone position. This is the vertebra. This is the sternum. Okay. Now you can see that because of the effect of gravity, these alveoli are collapsed. In any case, they are bad, right? In any case, they are bad because of ARDS, but because the ones at the base are even further squished because of the effect of gravity, whereas they are more open at the non-dependent area. So when you ventilate these patients, then these alveoli are more prominently ventilated. They get a larger share of the ventilation, and these alveoli do not get much ventilation from. When you turn the patient prone, okay, now these alveoli at the back were also not expanding. The chest wall at the back in contact with the bed was not expanding because it isn't restricted by the bed. Now, when these alveoli at the back are now only in contact with the atmosphere, they open up much more, and some ventilation now, which was not going there at all, goes to all these areas, and these alveoli now get opened up and they get a significant share of the ventilation. Okay, so it dramatically improves the ventilation to the dorsal parts of the lung, and that sort of homogenizes the lung much more. And you can see that more lung the ventilation is significantly homogenized. Plus, in the prone position, in the supine position, the heart compresses uh, the left lung, right? A significant part of the left lung, and the heart falls forward in the prone position. Again, that part opens up. Okay, so the prone position improves lung homogeneity, improves oxygenation, and because the lung becomes more homogeneous and the compliance improves, you can give lower tidal volumes, you can give lower pressures and lower FiO2. right? So that sort of protects the lung further. So the prone position is very good. And this trial, which was done in about 20 years ago, conclusively proved that the prone position also improves mortality. Okay, so if you give the prone position for at least 16 hours a day in patients who had moderate to severe ARDS with a PF ratio less than 150, the prone position significantly improved outcomes. So the prone position is no longer a rescue maneuver. It is a standard maneuver in patients who have moderate to severe ARDS. Now, in spite of all this, and in spite of all the ventilation and all those sort of things you do, some patients do not do well, and they get what we call as refractory hypoxia, which is variously defined. So these are some of the criteria which were used for ECMO. So we use these sort of criteria to define refractory hypoxia. And so the PF ratio of less than 50 for 3 hours or more, or less than 80 for 6 hours or more, or you also got a pH of less than 7.25 with a CO2 of more than 60 for more than 6 hours in spite of doing optimal ventilation and respiratory rate. So in that case, what do you do if you've got refractory hypoxia? Of course, you first need to make sure that there are no major complications. For example, a bronchial intubation, that there is no pneumothorax, so there's a collapse like, secretions or a mucus plug causing collapse. You need to make sure of that. Make sure that the patient is getting well ventilated. And if there is asynchrony with the ventilator, then you sedate and paralyze the patient. Make sure that, you've got the optimal PEEP either by a PEEP FiO2 table or with your this thing. If the patient has refractory hypoxia, it's okay to once give a recruitment maneuver to try and open the lung, not as a matter of routine. Give the prone position. You should have given the prone position by now. Nitric oxide was advocated, but it doesn't make a difference to outcome, but you can try it if you're desperate. And then finally, if nothing is working, and nowadays people are more and more experienced and they have expertise with ECMO, then you go to extracorporeal life support, which is extracorporeal membrane oxygenation, right? And in a patient with ARDS, with respiratory failure, largely with respiratory failure, then veno-venous ECMO is done. And I'm not going to describe veno-venous ECMO. We can take questions about that if you like. But so basically you take out blood from the vein, run it through the oxygenator and return it into a vein, the oxygenated blood into a vein, and that supports the lung. You also need to be aware of the cardiovascular system in ARDS. Now remember, you've got a lung which is damaged, so there's pulmonary hypertension. You've got extensive valvular collapse, which causes pulmonary hypertension. If you give too high a tidal volume or you give too much PEEP, then you will squeeze the intra-alveolar capillaries and you will further increase the pulmonary vascular resistance, and you will get severe pulmonary hypertension. So on top of hypoxia or hypercarbia, which is causing pulmonary vasoconstriction, you will also add to the pulmonary vasoconstriction by giving high levels of PEEP or high tidal volumes. And that can cause what we call as acute right heart failure, because the right heart may not be able to pump against the sudden increase in pulmonary vascular resistance. And you can see we are more and more aware of this because we are doing bedside echocardiography. And you can see over here that acute cor pulmonale, the right ventricle is much bigger than the left ventricle, right? And you can see the septum being shifted towards the right, and which should be flat is actually pushed towards the left side. So acute cor pulmonale is extremely important. If you see this happening, you need to reduce your PEEP, you need to reduce your tidal volume. And if you're still not able to get oxygenation or CO2 out, maybe you should go to either prone position or go to ECMO. Okay, so this is another thing that you need to keep in mind in patients with severe ARDS. What about drug therapy? Can we modify the course of ARDS with drugs? So the favorite drug which everyone has tried is steroids. Before that, let me just talk about neuromuscular blockade. So should you give neuromuscular blockade? There was some controversy because some trials from the French group a few years ago had suggested that a continuous infusion of cisatracurium for 48 hours improved outcome in patients with moderate to severe ARDS. However, those results were not replicated in another American study which was done. They did not find a difference in outcome with infusions of cisatracurium. So the question is, should you or when should you give neuromuscular blockade in ARDS? And I don't think you should give it routinely. Okay, these are the European guidelines. And again, what they say is that if you've got in mild ARDS, you don't need. In moderate to severe ARDS, if you're able to achieve lung protection with light sedation or deep sedation, you don't need neuromuscular blockage. But if the patient continues to be breathless, continues to have asynchrony, continues to struggle in spite of sedation, then you should go ahead and give neuromuscular blockade for up to 48 hours. So basically, you use neuromuscular blockade to ease your ventilation after you've tried to control it with setting the ventilator, matching the flow synchrony, and so on, and sedation. So steroids are a plus minus thing. The one very study found no difference. Okay, especially, and they said that it may actually be harmful two or more weeks after the onset of ARDS, and they use methylprednisolone. So some studies have actually found a benefit of steroids with ARDS, and this actually was given early in ARDS, right, from day 1 to day 5, and they gave very high doses of dexamethasone, 20 milligrams from day 1 to day 5, and 10 milligrams from day 6 to day 10, and they found a difference in mortality. So I would say that I don't think you should use steroids routinely in ARDS. If you have a steroid sensitive condition which is causing ARDS, some sort of connective tissue disorder or some kind of hypersensitivity pneumonitis, of course you should give steroids. But if it's just a simple septic ARDS, probably there is no need to give, and maybe you can give it a little later if you find that the lungs are not settling down. But the steroid is still open, and there are proponents on both sides of the coin. What about vitamin C and thiamine and the cocktail of hydrocortisone, vitamin C and trial? There is no evidence to suggest that it makes a difference. And in fact, in sepsis, at least one study has found a worse outcome with high dose vitamin C and thiamine and steroids. So I don't think there is any routine role for high dose vitamin C in patients with sepsis or ARDS. We are now coming to a sort of era of personalized medicine, and what all our trials were based on giving the same intervention to one group of patients and a similar one intervention to another group of patients. But now maybe we can, whether we have molecular markers or genetic markers or some protein markers or some biomarker, which tells us whether one strategy will work versus not. We've not been very, very successful. Okay. One group especially has identified what they call as a hypo and a hyperinflammatory subphenotype. They've looked at things like IL-6 and IL-8 and TNF, soluble receptors levels and protein C levels. Okay. And they found where these are low, they call it the hypoinflammatory phenotype. Where these were high, they called it the hyperinflammatory phenotype. The hyperinflammatory was associated with the higher mortality. Hypoinflammatory was associated with the lower mortality. Interestingly, they found, combining various studies, that the hypoinflammatory did better with low PEEP and conservative fluid therapy. The hyperinflammatory did better with high PEEP, liberal fluids, and the use of simvastatin. But again, these are hypothesis generating. These are not standard treatments. Okay. But it is interesting to see that hopefully we'll have some biomarkers or some markers to prefer one sort of treatment versus the other in patients with ARDS. Of course, make sure your ventilated patient is managed well, not just focus on the ARDS, focus on multi-support system, sedation, prophylaxis, DVT prophylaxis, nutrition, and infection control, extremely important. So the bottom line, I think, to sum up what I've been saying for the last 45 minutes or so, is that use low tidal volumes, 4 to 6 wells per kilo, limit the bladder pressure, less than 30 centimeters of water, moderate amounts of PEEP, reduce the amount of energy dissipated by controlling the driving pressure, not a very high respiratory rate, use the prone position, and when you're having refractory hypoxia, use extracorporeal support. So this is a very nice picture, which is there. So this is the PF ratio, like you go from 300 down to very severe of 50. So with mild ARDS, so low tidal volume all across the board, non-invasive ventilation for mild ARDS, low to moderate PEEP for moderate ARDS, higher levels of PEEP for moderate to severe ARDS, neuromuscular blockade in moderate to severe ARDS, same thing for prone position, and ECMO for very severe ARDS. Okay. So thank you very much for listening. Thank you for inviting me, and I'll be happy to take questions.
Thank you very much, sir, for the nice presentation of the topic of acute respiratory distress syndrome, especially in relation to different ventilatory patterns for the treatment of ARDS. Now, the session is open for discussion. And if you have any questions or clarifications to be made, please interact with Dr. Divatia. How many postgraduates are there? We are not able to say, Mr. Dr. Praveen.
Well, sir, this is faculty link. I think
Uh-huh.
Pronomi has to.
Okay. No questions from anybody? Okay, sir, I have few questions.
Yes, sir.
One is, what is the role of APRV, that is inverse ratio ventilation? So can you please explain, and is it routinely followed? That's not followed.
Yeah, so APRV is a interesting mode. So like you mentioned, it's a pressure control sort of inverse ratio ventilation. And you got very long, very high inverse
Inspiratory,
ratio. So
inspiratory, yes.
4:1, 6:1. And it is the ventilators that give APRV adjusted such that the patient can breathe spontaneously both at the high level as well as at the low level.
Yes, sir.
What happens with APRV is because you've got the high inspiratory pressure for a very long time, because the inspiratory time is very long, the lung stays open. So that sort of tends to keep the lung open. But you've got a very short expiratory,
Inspiratory.
the CO2 removal is not great. But therefore the patient needs to be breathing spontaneously. So you need a spontaneously breathing patient. You need a and the rate of CO2 clearance depends on the sharp drop as well as the rate of spontaneous breathing.
Okay.
Now, if you keep the PEEP with the lower level high, then what happens is that the difference from the top to the PEEP is actually quite low and you get less CO2 clearance. So what you do is you make sure that your inspiratory time is so long that there is some trapping, and that sort of causes the auto PEEP, which keeps the lung open. So APRV theoretically is attractive, but there are a few groups which have used APRV. We have been very comfortable with APRV because the lung looks very distended. The patient just keeps breathing, and it's quite uncomfortable because the patient, if you deeply sedate the patient, then the spontaneous breathing becomes too low and the CO2 starts rising. So the results with APRV have been mixed. Some groups seem to have got good results, but by and large, we don't use APRV. At least I have never not used APRV in these.
Okay, sir.
In fact,
So
I
also,
need more than when I see an APRV.
Okay, sir. And so also this high frequency oscillation ventilation you are not using, sir?
So high frequency oscillation was used earlier, and again, theoretically, it's a very good lung protective mode, because again, the mean airway pressure is very high and the patient just oscillates around that mean high airway. The alveoli open throughout the respiratory cycle. Unfortunately, what happened, there were two studies which were done. One was called the Oscar trial, and one was called the Oscillate trial.
Yes.
And they used it within the first week of ARDS. It's a routine strategy for ARDS ventilation.
Yes, sir.
One of the trials actually found no difference. The other trial, I think the Oscar trial, found a worse outcome with high frequency oscillation. And that may have been related to the fact that because the mean airway pressure was high, the cardiovascular dynamics were slightly worse. They needed more vasopressors. And in order to tolerate that high frequency oscillation, patient needed deep sedation, paralysis, and probably that caused a problem. So again, high HFO is not recommended as a standard or a routine, but if your patient is very hypoxic, you can try it, but as a rescue, not as a
routine
mode of ventilation.
Okay, sir. And one more thing is that since it is major, I mean, it's mainly the inflammatory process leading to the release of cytokines and causing the entire disease process. And corticosteroids, the results are not very satisfactory. And people started using, macrolides and statins and aspirin and other things. So, are there any new clinical trials or studies that concentrate on the prevention of the release of the cytokines so that they can prevent or minimize the severity of the disease or prevent the disease process? Are there any new trials? Because the basic problem is this is inflammatory process that releases cytokines that mobilize neutrophils, which migrate to alveoli, where they are activated, releasing pro-inflammatory mediators, so that the capillary alveolar barrier is damaged, increasing the permeability. So there is accumulation of the fluid in the alveoli and interstitial space. And also there is formation of the hyaline membrane. and there is a loss of surfactant. So all these factors lead to a reduction in the compliance, work of breathing is increased, and also the gases exchange is also affected. So are there any new trials? So concentrating on the
Looking at statins. So there was a trial which looked at statins. Uh, and again, on an average, on a global this thing, there was no difference in outcome. Okay, they've been looking at ibuprofen, they've been looking at some other molecules, interferon. They've looked at multiple things, but they have not worked. None of the trials have shown a positive result. Having said that, we need, if a trial is negative, it may mean that the molecule has worked in some and may have harmed others.
okay.
We don't have the markers to identify which ones it could harm and which one it could not. So like I said, the last slide, that personalized thing, in some groups, it may be that simvastatin may work better. So
Yes.
we now have to do trials which sort of enrich with, based on such biomarkers, that if some will get simvastatin, others will not get simvastatin.
Okay.
And then we'll see. But we have to wait for the results of these kind of studies. So as
Okay.
now we don't have any magic bullets or any particular markers.
Any particular substance or drug which can control this inflammatory process?
On a average population basis, no. But I'm sure there are some patients with some conditions who will benefit, but we've not yet identified all of those.
Sir, in your practice, how often do you come across anesthesia-related ARDS? For example, full stomach, failed intubation or difficult intubation, regurgitation, aspiration, Mendelssohn syndrome, and ARDS, or prolonged surgery, fluid overload, particularly in susceptible individuals like asthma and COPD. So, how often do you come across this type of cases?
So fortunately, I think all anesthesiologists are doing a great job.
Okay. Yes.
We don't see this very
Yeah.
often. Anesthesia is quite safe.
Yeah.
So aspiration, although the Mendelssohn syndrome has been described, even you may not have seen so many
Yeah.
cases. I've
Correct.
only seen a few. Although aspiration does occur, maybe not in the setting of anesthesia, often occur in the setting of medical disease, like for instance,
Yeah.
strictures or esophageal tumor.
Or alcoholic meeting with an accident, roadside accident, unconscious aspiration. Correct. Correct, sir.
Strokes and those kind of things.
Okay, sir.
But as such, patients coming from OT with aspiration, I think may have seen a couple of cases, if at all.
Okay. Okay, sir.
And yes, trauma, yes, would come. And then you don't know that because of anesthesia, but it's just
Okay.
trauma. And
Trauma only, yeah. Roadside accident. Yeah.
sometimes I think anesthesiology is a little enthusiastic about fluid administration.
Yeah.
But that's not ARDS. That's fluid overload, and that gets corrected quite.
But in susceptible individuals like bronchial asthma and COPD, fluid overload, theoretically speaking, it can result, but usually it doesn't happen. Yeah, thank you. Correct.
Usually don't create a very serious problem.
Correct.
And it's very difficult to distinguish the whole reason why a patient lands up on a ventilator and ARDS, say the perforated bowel peritonitis, perforation peritonitis.
Yeah.
They do land up with ARDS, but again, it's inflammation because of peritonitis and sepsis, and so I don't think you can say anesthesia. Maybe a little more fluid may have been given, maybe a slightly high tidal volumes may have been given, but that doesn't really make a huge difference in that short span of time that we are anesthetizing the patient.
Correct, sir. Thank you very much, sir. Dr. Praveen, please take over.
Then the moderators, if they have any questions. Vijay Babu Garu.
Sir, in your practice, what is about the role of this neuromuscular blocking agents? When you will start? When you will indication of giving a neuromuscular blockade? Depending upon PFD ratio or due to just because of the patient has a respiratory distress is more respiratory rate and dysynchronia.
Yes, sir. So I don't think it's only the PF ratio.
Yeah.
But if the patient has moderate to severe ARDS and there is dyssynchrony, like you said, or the patient is struggling to breathe and it's difficult to set the ventilator to match the patient's respiratory breathing, and it's not controlled by sedation, then we would definitely give a neuromuscular blocker. So,
but sorry, you can go ahead.
No, so in the early years when I started, we used to be quite liberal. Then we became very restrictive. But now I think we sort of let's say we don't hesitate to give it where we feel that we are not getting control of the patient. But But it's not that you cannot use relaxants. It's not that you
Yeah.
must use
My
relaxant for
practice is
everything.
start when the patient is severely
Yes.
distressed, and also at the same time, plateau pressure is also going very high, even the low tidal volumes, and the PF ratio decreases. Before proning the patient, I'll give one bolus of one trial of the neuromuscular blocking, and this increasing the saturation, we'll wait it. Otherwise, immediately we'll go for a prone position.
Yeah.
The definitely prone position will definitely increase the saturation and the PO to repair ratio also. And what one more? Yeah, please.
When you're giving prone, generally either you're giving deep sedation or paralysis, because otherwise it's difficult for the patient to tolerate.
But the another second question is, what type of etiology, primary etiology leads to ARDS is the indication of this steroid, especially methylprednisolone. The primary cause, you know that this primary cause leads to the ARDS, and when you the type of indication of this steroid. Any time you're using a steroid for the specific purpose of the etiology leads to the ARDS.
Sometimes you've got these immunological conditions, you've got some eosinophilic pneumonia, you've got a connective tissue disorder, a flare up of Wegener's or something like that, which is causing. Then maybe you can definitely start off the steroid. Otherwise, probably not. And in the standard, usual sepsis-induced ARDS, no.
Yeah, sepsis.
And of course, in COVID, we knew we used to always give dexamethasone, but not anymore. I mean, now, hopefully, COVID is not there anymore. So,
yes. How many hours of prone position you will practice, sir, per day?
So we are
how
doing
many sessions? How many sessions? How many day time per day? Hard question.
So, like the study said, it's 16 hours.
Yeah.
16 hours, I think, because by the time you take your round, you finish this thing, you decide to give prone, it is say 12 o'clock, and then you give the patient prone position, then you turn the patient prone next morning. By the time it is 8, 9 in the morning, it's about 16, 18 hours. So I think it'll be something like that, So
yes. Yeah.
If the patient is doing well, maybe we might even continue the prone for a little longer, and sometime even 24 hours. And then
how many sessions the patient is not improving, and maybe improving when you're picking a supine and the patient is deteriorating. Like that, how many sessions will continue? Or you can go for ECMO. When you the time factor go to the prone to the ECMO. And that is, I already done is 6 or 7 sessions of the prone. The patient still, when the patient making a supine, they is deteriorating. Then what is your call? When you call, take a call.
I'm not as patient as you. I won't wait 7, 8 sessions before going for ECMO, but 2, 3 sessions you definitely give a trial.
Yeah.
People who don't even give prone position, they just go for ECMO,
Yeah, nowadays, yeah. Now the corporates are, once the patient is very bad, they can go ECMO directly, I think, depending upon their period of
very good at ECMO, and like ECMO circuits and the machinery is so much better. So that's also some patients cannot be turned prone for various reasons. So,
yeah, maybe some trauma and
yes.
Especially neuro cases, head injury, and that is a very tricky patient head injury with
yes,
ARDS. Okay, sir. Thank you. Thank you very much for your wonderful presentation.
Thank you, sir.
Padmaja ma'am, Padma Michelle ma'am, if you want to add something.
Elaborate, and sir has given a very good slides about the ideas. Sir. Thank you so much, sir, for a wonderful session.
You are.
Sir, excellent presentation, very crisp and very simply, you made it very simplified for the postgraduate, sir. Thank you, sir. Sir, I just want to have one question. Sir, is there any tocilizumab, any role is there?
No, except COVID, of course. In the standard, again, in the usual sepsis ARDS situation, tocilizumab will probably aggravate the ARDS. But we have used in a couple of conditions with a rheumatoid arthritis flare up, a patient had Still's disease. So again, a steroid responsive when it is treating, whether tocilizumab is likely to treat the underlying condition and the patient has an ARDS, then maybe there is a role. But as a matter of routine, definitely not. So in ARDS, you will get high cytokine levels, you will get a high ferritin level, okay, just because of the inflammation. And just because the IL-6 is high or the ferritin is high is not an indication for tocilizumab. We need to have, some other situation where tocilizumab is likely to work, because sepsis ARDS will get that usual cytokine storm. In fact, the levels which you get in COVID were much lower than what you get in sepsis-induced ARDS. But tocilizumab is not good for sepsis, right? So, but if some other indication, then maybe you can consider.
Thank you, sir.
If there are no other questions from the moderators, may I ask Pranomi, are there any questions in the chat box?
No, sir, we haven't received any question yet. So, yeah.
Okay.
So
There are no questions.
Yes, sir. So I'd like to thank all the dignitaries for the wonderful deliberation and the informative content you all have shared to make this session a very success. So with everyone's permission, I'll be ending the session over here.
Thank you, sir. Good night.
Thank you so much.
Thank you so much,
Thank you so
everyone.
much.
Thank you. It was a wonderful session.
Thank you so much.
Thank you very much, sir.